Thank you very much. It is so great to be back here. And I just want to say thank you to Leslie, to Luigi, and without the two of you, we would not be here. And I want to give a round of applause because their dedication to this is why we've been here for 10 years. And you remember where we started in a little room with one bathroom. Anyway, so thank you. I want to trick or treat here. So Leslie's going to end up pulling me off the stage, I know, but I've got a lot to cover here. So first, theory. So talk about airway pressure release ventilation. It's been around. A lot of people have never used it before, still, very misunderstood, but it's been available since 1987. First available on this ventilator, and you can see that was our screen. That's all you had to work with, and so it was a little challenging, but it's available now on most any critical care ventilator. You might see it named by vent, by level, by phasic APRV, but they all generally have the same idea. So what is APRV? And in the simplest form as it was first described by Dr. Downs, it's CPAP with release. So as you can see here on this tracing, this doesn't work. Here, CPAP, you have an airway pressure. The patient can spontaneously breathe with really no change in the pressure. And APRV, you see the exact same thing, except there's these two big gaps. So if we filled these gaps, it would simply be CPAP. But what we do is we actually provide a release phase, so the airway pressure is lowered in order to create a volume to get rid of CO2. So that is the clearance of CO2. So we actually looked at a 30-year evolution of APRV because we wanted to look at what exactly are we studying here. And if you read this paper, you see it is all over the place. And it's called APRV. From pressure control, 1 to 3, 1 to 1, 2 to 1, 4 to 1, it's all over the place. So I wanted to actually break down, and you're going to hear maybe a new term to some of you, and we call it TCAV. So is APRV the same as time-controlled adaptive ventilation? And as Luigi has mentioned several times today, the personalization of a mode to a patient. So the mode versus the method. So we're going to use the analogy of making a Halloween cake. Okay, so we're going to have the mode ingredients. And actually, APRV uses the same ingredients as any mode. Pressure, flow, volume. It's just how you actually set it on the ventilator. But if the right amount of these ingredients are not used, the outcome can be vastly different. So here's our ingredients for the cake, and here's our method. So what's similar is we have mode ingredients or settings, and we have method of application, or the actually way that you set this mode. And so if applied in one method, you may have a different outcome. So in applied with the TCAV method versus you may have a different outcome. Okay, so actually, and the reason I say this is, so here is an example of, this is TCAV. So this is APRV set with a, and I'm going to go over all the settings, but you can see this waveform and the mode is the same. So if you look just at the paper, you're going to say that patient was on APRV, right? And then you have to look at the T-low here. Versus this is a patient, yep, he's already on APRV. This is bilevel. Now you see the T high is 1, but it's a rate of 32, so we already know what the T low is based on the ratio. And look at the waveform. A lot different. This goes all the way to baseline. This is at 75%, which you'll know by the end of this talk. And also a difference of, this is basically a 1-to-1, and you have almost a 5-to-1 IDE ratio. So that's just basic theory. Now let's go into settings and best practice. So what are our settings? In APRV, you have a P high, a P low, a T high, and a T low. And it's together combined, we call this the CPAP phase. T high plus P high is the end inspiratory lung volume, and then combined the P low and the T low. We call this the release phase, and it is the end expiratory lung volume. And the patient can breathe throughout the entire respiratory cycle. So we have this actually available. There's a website, tcavnetwork.org, and if you go there, there's rescue settings, standard settings, there's some documents there. But these are the settings in general, and are your P high, P low, T high, and T low. So now let's go through. Our P high. P high, essentially is in pressure control, restoring FRC. That's what we're trying to gain, is restoring lung volume so that the patient can take a breath at a more optimal lung volume. So how do we do that? Well, one reason is because we want the patient to breathe on the steep portion of the pressure volume curve. So not at reserve volume, not at TLC, but somewhere here at FRC. So how do we get there? So if you're transitioning from a conventional mode, if you're on pure volume control, you can use the P-plat, okay? If you're on pressure control, you would use your inspiratory pressure. If you're on a dual targeted mode, suffice to say there's no plateau phase, and usually you just see a peak pressure like on PRVC, auto flow, you're going to use the peak pressure as well. And then if you're transitioning from high frequency, you use the mean airway pressure plus 2 to 4 centimeters. So how do we know once we transition what's too high and what's too low? So is my airway pressure too high? Well, if you look here, and this is an extended T high, but you can see there's an inspiratory phase where the patient takes an inspiration, but look at the expiratory phase. It's prolonged. So if you can just envision the patient is constantly breathing out. So they're, as Dr. Bashi said earlier, they're defending their lung volume. So that might be an airway pressure that's too high. Versus, is it not high enough? And if you can look here, this airway pressure, this is where it's good to be short and wide. Tall and skinny is not good. And you can see that this patient cannot even take a breath. They can't sustain that breath. And you can see also it is in excess of the machine flow volume. Flow characteristics. This is the machine here. This is the patient actually pulling through the machine breath. So the patient, the machine flow is 40 liters, where the patient is about 80 liters. So that's a patient really pulling. So you might want to consider that that airway pressure might not be high enough. There's a couple reasons for that, and we'll go over it. So is it just right? And the 3 bears here. So this is actually a spontaneous breath and then a natural passive exhalation, and you can see that here. And there's really no change in the airway pressure. Sorry, I want to go back here because I do want to show you this. And this is the difference. My goodness. Do you see here also? Look at the change in the airway pressure. So the patient, we call it carving out the airway pressure. So when they're able to pull that, make that dip in there, again, it might not be high enough. So taking a nice spontaneous breath, little change in airway pressure, that might be just right. And just expand a little bit. So here is an active exhalation. Look at where the load on the expiratory side is. It's here. It's in the, this is normal, sorry. The passive exhalation, and then it decelerates. Versus the opposite. If you flip this around, the patient loads towards the end, and again, they're defending their lung volume. So is a P low redundant with TCAV? So, it's kind of like putting that behind a rabbit there. If you, we're using time. So in using the TCAV method, the P low is not necessary as long as you have the T low set properly. That's very important. So if you decide that you have a different way of setting T low and it goes to 0, you're going to need a P low. You need some way to retain that airway pressure. So a P low only when the T low is set with TCAV. And you can see that gas flow comes out of the airways through the endotracheal tube, and then so you have your first resistor right here, and then you have a pressure drop. and then it goes through, and this is all enriched CO2 gas, and then it gets to the PEEP valve, and we slow it down. So we've already got it slowed down with time, so we don't need to slow it down with airway pressure. And you can see also here just a rendition of what it looks like. As you mentioned, the airway pressure reaches, when you're set in pressure format, that the pressure is reached early, but also look at the pleural pressure. So if it lags here, it's not going to suddenly drop. It's going to also lag on the release phase, and this is the retained airway pressure. So you can see this in this tracing here. So now let's talk about T-high. This is actually what controls the rate with APRV. So this is, and we'll go over some studies a little bit later, but this is the rate controller and maintains alveolar stability. Now, Luigi showed another one of these slides, but this is just looking at the difference of, so if I have an inspiratory time set at 1 second versus 5 seconds. And this is a rat lung, so you can see that's what happens in basically 1 second. Oh, well, it went all the way. Maybe it's flipped. And, oh, it just didn't stop. So, at 1 second, there's just hardly any recruitment at all. Right there. Let's see. So what do we... There we go. So how do we set our T-high? So we know it's a rate controller, so we can break it down into two groups. So do we have basically a normal lung, or are we using this as a rescue? If we have normal, we look at a normal pH, PCO2, they're hemodynamically stable, and less bulk ventilation is required. So these might be some ranges that you could consider. So like 4 to 6 seconds is a rate of 10 to 12, and so on and so forth. So adults, pediatrics, and neonates. However, if you are in a rescue scenario with an abnormal pH, PCO2, like Luigi's patient that he presented, hemodynamically unstable, more bulk ventilation is required. So you're going to use a much lower T-high. Okay, so here is a way to also help you figure out if you're transitioning from a conventional mode. This is a formula that you can use, very easy. So you take your 60 divided by your respiratory rate, okay? Then you're going to subtract your T-low. That's your T-high. Very easy. So I take a respiratory rate of 26. What's my T-high going to be? Well, I take 60 divided by 26. That gives me a cycle time of 2.3. I'm going to use, you can, and here you can guess, 0.5, 0.6, somewhere around there. It doesn't have to be exact, but just use 0.5. Subtract that, that's going to be your T-high. Very easy. Really easy to set. You get your first blood gas. You can either go up or down from there. And as Luigi also said, personalization, and that's what we're looking at. There's a lot of new papers out about how to personalize mechanical ventilation. Very important. That is, the T-low is personalized. That's why we don't like to say a protocol is 0.4 to 0.6 seconds on everybody. It's not, and that's where we came up with this 75%. So it is personalized to each patient's lung mechanics. It's set to 75% of peak expiratory flow rate when you have restrictive lung disease. But if you have obstructive lung disease, which we won't really talk about, but I have an example, but you're going to set it to 50 to 25% of the peak expiratory flow rate, for the simple fact that your peak expiratory flow rate with chronic obstructive disease is about 20 liters versus restrictive is about 60, 80 liters. So at 20 liters, your angle is very flat. So it takes a long time to get to zero, versus restrictive, you have a very steep angle. And we'll go over some examples of that. So how do we calculate the T-low? Again, an easy formula. The peak expiratory flow rate in this example is minus 100 liters. So we're going to take that and we're going to multiply it by 0.75. Our goal is to find the T-low terminating at 75 liters. So right here, it's a little high there on the diagram, and so that's where we want to set the T-low to 75% of that number. So that is clear, I'm sure, to everybody. So, absolutely clear. So here is an example, and we can actually go out maybe at the break and show this. So if you freeze your waveform and you find your peak expiratory flow rate, in this example, the peak expiratory flow rate is 66 liters, 65.8. So I want to do the math now, and I want to take 66 times 0.75. My goal is to terminate at 49.5. So if I look here on this example, it's terminating at 53. So it's pretty close. Now I can, if your ventilator will allow you to, let's say that this is at 0.4. If you go to 0.42, then you'll probably be right on dot, okay? But actually, if your CO2 is okay, if you're ventilating okay, you may as well just leave it right there. It's a little more than 75%, but you can leave it there. Just another couple examples, because I know the T-low is probably the most important part of this mode, and it just needs a little more understanding to set. If you set the T-low at 0, you have 100%, okay, of your termination. If I set it to 0.5, in this example, I have 75%. If I set it to 0.6, I have 50%, and if I set it to 0.7, I have 25%. Does the math make sense? Okay, so it's kind of reverse. So the percentage is on this side, right? And it's the percentage of that peak flow. This is perhaps the easiest thing to do. Is if you look at your waveform and you take that, which is your expiratory flow, and you cut it in half. Make a cross, okay? If it is anywhere right here or above, your T-low is too long. You need to cut this in half and then cut this in half, and that's where the 75% is. Does that make a little bit more sense? So just a couple different analogies to help you understand. And this is actually what happens when you have a decrease in compliance. So you have a T-low of 0.5, 75%, and patient goes to the OR, gets blood products, goes under anesthesia, and then they come out for the exact same T-low. That's why we don't like using T-lows, set it from here to here. 75% is now, I'm now at 25% for the exact same T-low. So I need to take my T-low and go from 0.5 to 0.4 in order to bring that back down to 75%. Okay? And you'll see this. This is actually an example. Funny how that happened. So here is a T-low of 0.45, and you can see the angle here, and this is 75%. And then now this patient, here is the chest x-ray. It's still ugly, trust me, that's not good, but it got uglier. And this happened when the patient was disconnected, and the tubing was disconnected inadvertently. And look at the loss. So now, just to blow it up, look at the angle changed. This is a little blurry, sorry, but so I have a 45-degree angle here. It got steeper, and now my 75% is up here versus down there. So I needed to take that T-low and go from 0.45 back to probably about 0.35, I think, which is what we did. So one more just example here to demonstrate. We actually looked at this under in vivo microscopy. What happens to the alveoli at 75% versus 25%? And this is the stress strain. And so at 10%, you have, this is the CPAP phase. And you see the alveoli are recruited. Everything looks pretty stable up here. But what happens at the T-low? This is on the release phase. So at 10%, you have a big change from CPAP to release. You see all of these alveoli are collapsed here. Then we tighten up the T-low, and then you go to 25%, and you have some less collapse. 50%, you still have some collapse, but not nearly as much as here. And now 75%. You have almost no collapse, and actually under in vivo microscopy, it's less than 10% change between CPAP and release. So here's just the videos. This is at 10%, and you can see, look at the difference in the see if it'll play again. Yeah, so the difference in CPAP to release a lot of loss in lung volume. And now here, this is 50%, okay? And do you see what I mean here by that? There's my cross, right? That's 50%. So do you see how the termination is at the halfway point of your expiratory flow? That's really easy to spot. As soon as you walk in, you don't know exactly what the T-low needs to be. You know it needs to be shorter, okay? And then here's 75%, almost no change in alveoli, and at 75%. It's a little grainy because it was on a wrap. Okay. So if we were to throw out some settings, again, just to get you started before you get your measurement, you could say for adults, 0.3 to 0.6, pediatrics 0.2 to 0.5, neonates 0.15 to 0.3. Just a couple things here. We're actually working with a group out of Tampa, Florida on neonates, and they're using auto-release, and they're having a lot of success with it. So we're anxious to work with them on that. The other thing is, remember, some ventilators have, and it sounds crazy, but 0.3 seconds to 0.4 seconds can be like this, okay? So if you want 0.32 and not 0.3 and not 0.4, you might not be able to get it on some of the older ventilators. So this is really important. What is peak expiratory flow rate? So we get a lot of confusion here of where to measure your peak expiratory flow rate. If you see anything like this, any of these expiratory spikes, do not use that as a measurement. That is gas that's recoil in the circuit. It's gas compression. You have to shave that off. What you want to do is start, your peak expiratory flow rate is where you start to see a decay. Okay? So you can cut these off, and do you see how where it starts to separate and it starts to actually angle? That's your peak expiratory flow rate. So don't try to measure it down here at 80 liters. This one in this case is going to be measured at about 45, 50 liters. Okay? So the difference there. Just another example of what not to measure and what a normal one would look like. Let's see. So what are factors that influence peak expiratory flow rates? What could make something appear that with that spike or change suddenly? So you can have the size of the artificial airway. If you have to re-intubate somebody and they're on APRV, check the peak expiratory flow rate in your T-low before and after. So if you go to a larger tube, you might have to take your T-low back down. If you go to a smaller tube, you might have to increase it. Okay, so it's not going to be a one-for-one. And we all know that endotracheal tubes get dirty over time, right? They biofilm, so they actually get smaller in a patient. Obstructions, if you set a P low, you're going to get a different peak expiratory flow rate. Secretions, and if you still use HMEs or expiratory filters. So here's an example of, so you can see that spike, right? So we know we don't want to measure that, but look how flat that waveform is. So just imagine that you come in and you can say, oh, that patient's probably a COPD patient, right? It's got that flat angle, a low peak expiratory flow rate, except you look over and you see this. Okay, so that actually is going to create that waveform. So you straighten that out and everything changes. Your peak expiratory flow rate goes up and your T-low is at a much different point. And actually that was that patient. So see how my COPD resolved immediately. Okay, so here's another example, and I've had this happen several times recently, is that the Ballard suction catheter got stuck down in right at the endotracheal tube, so of course it's going to look obstructed, and you pull that out and voila, so everything's resolved. Now, the interesting thing is you're not going to see this with PEEP. PEEP already has an expiratory retard, right? So it already is pinching on the expiratory side. So if you have a P low of 0, you're going to actually see the mechanics from the lung. You're going to see what's coming back at you. Here's another example. So this is, look at the difference in tidal volumes. So the tidal volumes were cut in half, and the waveform looks like this, and the HME was completely saturated. They changed it out, immediately resolves. That's the other thing is, if you check a blood gas and all of a sudden your stable, normal patient became very acidotic, look for these things. Is the tube kinked? Is the suction catheter, stuck down in the endotracheal tube? Do I have a wet HME? All of these things are, trust me, these are examples, these are live examples of what have happened. But a restrictive patient can become obstructive, and I don't mean with COPD, but I mean they can become obstructive. So here is an example, and there's some telltale signs here. Do you see all these jagged edges? That's usually, who was talking about the turbulence of the inside of the circuit? Well, this is on the inside of the endotracheal tube. So this is the turbulence coming out, and then all of a sudden, this waveform went to this immediately. So I know that my patient didn't, develop COPD, or, why is it flat? And it was actually this. So pulmonary contusion started breaking up, and this endotracheal tube became full of bloody secretions, and the interesting part was it created a one-way valve. So it was, thick bloody secretions, so you could pass the suction catheter in, right? But when you came back out, it actually collapsed. And so gas is going in, gas is not coming out. So this is where you would stack. It was actually interesting because you could tell that waveform, we checked everything else, that patient got re-intubated and everything was resolved. This is compliments of Dr. Manugan, who said, I think my patient is, I think it's secretions, and sure enough, suctioned, and this is all it was. Patient was full of secretions. This is the other thing is, and I'll actually reserve that because I have some examples. Oh, right here. So factors that mobilize secretions: recruitment and high expiratory flow rates. So together, this is what APRV actually provides, not the secretions, but the recruitment. So this is an old study back in '89, and they looked at two-phase gas liquid transport. And what they did was they created a synthetic mucus, and they looked at inspiratory and expiratory flows. And actually, as you inverse the I/E ratio, the expiratory flow became higher. Okay, so we actually noticed this in our APRV patients, and so we noticed that on conventional, their expiratory flow rates were, in this example, 40 liters, and transitioning over to APRV, 80 liters. So almost always they double from your conventional mode. Well, what does that mean? Well, a lot of times, all of a sudden, the endotracheal tube would become completely obstructed right after transitioning, and you would just start suctioning a lot of secretions. So we had some respiratory therapists who were challenged with a project that they had to do, and they actually took this study and they redid it, and they created a bronchial tree with little balloons, and they filled each balloon with Guire's gum. Okay, so they created this mucus. And then what you're going to see is time-lapse video. We sped it up, but for the exact same amount of time, comparing pressure control with APRV. Pressure control 1-to-1 with TCAV, okay? No difference in airway pressure, no difference in rates, all right? But what you're going to see is this is the pressure control, and you can watch here that, maybe, okay, and so you can see that the little vibration here, and you can see the well kind of moving down a little bit, but it's all still stuck there, okay? This is the pressure control 1-to-1. So for the exact same time frame, we're going to now switch over to TCAV. And so this is the exact same amount of time. Oh, is it not going to run? Okay, there we go. For the same amount of time, and then, see, is it the same video? It is. Oh, that's why. Sorry. Okay, so for the same amount of time, this one is the APRV example. Maybe? There we go. So the same amount of time, within about 3 to 4 breaths, the balloons are empty. Completely empty. Where did it go? Look at the bronchial tree. And this is what happens a lot of times when you switch over to APRV, that all of a sudden all these secretions started coming up the endotracheal tube. And that's actually what we looked at. So this was a plastic model, okay? So we actually translated this and looked at TCAV using simulated mucus in pig lungs. And what we found was essentially the same thing. So that as the flow rate increased, that the secretion, the movement of secretions increased. And that when we compared that with conventional ventilation, that there was really no proximal movement of the secretions, but as you went to 75% on TCAV, the movement of secretions increased dramatically. And here's just a plot of mucus movement. You've seen it all. Okay, so just as I said, just a couple quick slides on COPD. This is actually a real COPD setting, okay? And this, so first of all, do we need to recruit the lungs with real COPD? No, they're usually at total lung capacity, right? And so we don't need a high P high, so you can see the P high is only 15. Do we need a long T high to recruit? No, we need to bulk ventilate more. So the T high is actually 1.4 because the T low is so long, 1.8 seconds. Now what's interesting is almost 2 seconds. Do you see hardly any change here? Right? I mean, it's still at 50%, so we can still go out even further. Can you believe that this is the same patient? Can an obstructive patient become restrictive? Yeah, you can lose lung volume, right? So this is the real COPD patient with those settings, and then when she receives fluid, had bibasilar collapse, then we needed to change the settings. So again, look at the peak expiratory flow rate. It's only not even 20 liters, and it's very flat. And then here it almost doubled. It almost went up to it's 40, and then the T low had to change. So very different. And again, you can assess that, which I don't have, unfortunately, is that this, when it went to 40 liters and all the way to 0, the angle was much steeper. Not going to talk really about actually how to wean a patient, but I just wanted to bring this up, stability. Okay, so now, because what we've talked about a lot was the confusion of using APRV. Everything looks good. You've got a good blood gas, chest x-ray looks fine, let's take them off. This is, you know, you kind of used it as a recruitment maneuver. And so they're good to go, they're good to come off. And we actually wrote a paper about, we call it the broken lung syndrome. So what I envision this as analogy of I'm stepping off stage and I fall down and I break my wrist. And you guys take me over to Guy's in St. Thomas, and Luigi refers me to the orthopedist there who says you have a fractured wrist, reduces my fracture, puts me in a beautiful pink cast, and then does an x-ray afterwards. So afterwards, it's perfectly set, everything looks good, okay? So what's the next step? Cut the cast off, right? Why not? My bones were set, right? I mean, it's in alignment, everything looks good. This is the analogy of a broken lung. It is not necessarily ready to completely come off of airway pressure, right? You are still pressure dependent. And this is an example of a patient that actually was taken off of APRV. Everything looked good. The blood gas looked good. The chest x-ray looked good. This is after 2 hours. Bibasilar collapse. So this was a broken lung. It was not ready to have the cast cut off yet. So that's just one thing to look at. Everything can look beautiful, but just, temper your desire to immediately take them off. So now I want to just go over some myths and misconceptions. So we actually just published this paper recently, and I urge you that if you have any questions, if you still believe in some of these myths and misconceptions, we'd love to hear why. But it took us nearly 300 references to basically challenge the top 10 myths. Okay, so we're going to go through these 10 myths. So myth number 1, APRV is too difficult to use. So these are all things that we have read that have been published in papers, and if you read the actually myths and misconceptions paper, you'll see where they're cited, where some of the claims have been made. But the interesting thing is that it's been available since '87. It doesn't require a special ventilator, not like if you go on to high frequency that you have to have a special designated ventilator. It's simply another mode, another option here. The learning curve exists for anything new, anything that you try new. ECMO or high frequency, anything has a learning curve. It's been used successfully on tens of thousands of patients, over 30 years worth. A lot of people still use it as standard of care or rescue in many hospitals. And this is the real interesting thing, is that after the ARMA trial, they actually studied, did a questionnaire with the top 10 sites that had the ARDSNet study trial there. And they found that they perceived there was a lot of barriers. The PEEP FiO2 scale, it's not, that easy to use. So again, we don't believe that APRV is the only mode with just a learning curve. We hear this a lot. APRV causes barotrauma, and it is not questioned. It is emphatic. It does cause barotrauma. But here's the problem with that. Barotrauma is multifactorial, and in fact, there's no evidence that any component alone or in combination is the sole cause of barotrauma. And this means that compared to any other mode, compared to invasive, non-invasive, and they actually looked at a study of 5,183 patients, and there was no correlation between barotrauma and the mode or any setting. Systematic reviews, meta-analyses have shown that there is no difference in barotrauma rates when looking at any modes and compared to APRV. More recently in COVID, the actual rate of barotrauma increased, but it was not specific to any ventilator mode. And actually, a systematic review suggests that mortality appears to be lower with APRV and no evidence of risk of barotrauma or adverse events when compared to low tidal volume in these studies. APRV generates high tidal volume leading to volutrauma. And this is really interesting because there's a lot of claims that APRV in itself, and actually there was the patient that Luigi had, that if we switch over to APRV, surely we're going to cause these high tidal volumes. And actually, what's cited is 2 studies are frequently referenced saying that APRV has higher tidal volumes. So the interesting thing is if you pull these studies, that Rasainen in '91 showed that the tidal volume in APRV group was 9, but the tidal volume in the conventional group was 12. So it just is funny that, APRV was claimed to have higher tidal volumes in this study, but yet the conventional group was higher. And then in the other study that's referenced is the 2004 Varpula, and both groups had the equal tidal volume set. Also, Newman is referenced that tidal volumes with greater a liter cause large pleural pressure swings, could lead to villi. But if you actually read that study and break it down, the tidal volumes that were above a liter was because the T low was set to 2.5 seconds. As the T low was reduced to 0.5 seconds, as is typically used with TCAV, the tidal volumes came down greatly. Also is the issue with the ventilators kicking out, generating dramatic tidal volumes. What do we mean by kicking out? Well, first of all, let's go over this. Again, does APRV have higher tidal volumes just because of the mode the name of the mode or just because you're setting it. So here is an example of this patient was already on APRV. But if you look, what percentage is this here? It's at least 50, right? If not 40%, okay? So what do we need to do? We need to reduce our T low. So we take our T low from 0.5 to 0.35. It's still not 75%. So we go to 0.32. This is where that gradation is really important. We go to 0.32. Look at what happened to my volumes. So I went from 451, 313. I went back up here a little bit, but that was because the P high went from 26 to 30. So again, really important that actually there's usually lower tidal volumes when you're rescuing an ARDS patient using TCAV. So let me walk you through a patient. Conventional ventilation, so if I have an airway pressure of 34, what's my P high going to be? 34, right? I know it's scary to set, but it is already 34. So I'm going to use a P high of 34. I have my rate of 24. This ventilator is a little unique because you just set the rate, but you have to set the T low. And so I'm going to set my rate at 24. And this is a patient on conventional ventilation is getting 5.9 milliliters per kilogram of tidal volume. So I switch over to TCAV. So that is my T low. So I have 34 over 0. Actually, my rate is only 16, and my T low is 0.35. And was it 16 before? Yes, it was 16. Sorry. My T low is. I actually came down on the rate, and my tidal volumes are down to 4.7 mLs per kg. Okay, and I've been able to lower my rate. Why? Because I have greater surface area. Because I've been able to recruit, my CO2 comes down, I can drop my rate. So my chest x-ray is improving. So I go from 4.7 mLs per kg with these settings, and my tidal volumes actually start going up. No change in any settings. My airway pressure is the same, my T low is the same, but my tidal volumes are now going up. So no change in settings, but you already saw that. Slow down, Sparky. So your tidal volumes are going up on their own. So now you can actually come down on the airway pressure because this is recruiting. You can come down on the airway pressure. I'm coming down on my rate. You're becoming hyperinflated, so we need to back off. And my ABG, not in kilopascals, divided by 7.9, is I'm flattening out here. And so I reduced the airway pressure down to 22. Remember, we started at 34. And so now we're down to 22. I still have flattened diaphragms, and my volumes are still only 382, 5.1 cc's per kg. But I'm slowly lowering the airway pressure. Now that kick out, this is actually really important. This ventilator is known to actually kick out the T low. So even if you set it at 0.5, you are going to come in and you'll see tidal volumes a lot of times, and it's because it's an attempt to synchronize, because it used to be pressure control, and then they basically changed it over to APRV. But if you see here, you have 550, and now all of a sudden I have a liter tidal volume. So a lot of people are like, oh my God, I recruited. But look at the difference in the width of the T low. No change in the settings, but it kicks out on its own. And here's another example, and this is the Servo U. It does the same thing. T low is set to 0.5, and you can see the difference in this width versus this width. And look at the difference in the tidal volumes. And then here's actually a video. So watch here, that's properly set, but watch this next breath. So it just automatically kicks out. So you're going to see an increase in tidal volumes and with no change in settings. This happens a lot of time if there's a leak, if the patient makes an effort, if there are secretions, anything that mimics a breath, a spontaneous breath. So it tries to synchronize and kicks out. So now it's back to its normal for a couple of breaths, and now watch, here comes, look at my volumes, and watch, here comes, there we go. So, that's just another example there. Another couple examples. Just a big increase, and this is even a huge increase here. Even at 0.4, it just went out to almost a second. And then the same thing happens on this ventilator. That's too grainy, you can't see, but the volumes increased dramatically. So myth number 4, I know we talked about this today, and actually increasing right ventricular afterload and strain. And actually there's no evidence that APRV increases right heart strain compared to any other mode any more frequently. And meta-analyses in many animal studies show greater survival in APRV with better hemodynamics and actually lower vasoactive doses. So I just want to quickly run through a study, a case study. This is a 53-year-old, 60 inches, 60 kilos, status post hanging. She was on nitric. These are norepinephrine, maximum dose, dopamine, dobutamine, neosynephrine. EF is 35%. Here is my my current conventional settings, 726, 93, that's still like a divided by 7, yeah, so, and then my PO2 is 46. So this is the initial chest x-ray. 100%. Oh, and 100%, yep. So here's the initial chest x-ray. Dim the lights, please. No. She's transitioned to a 4-to-1. My airway pressure on conventional, this is still on PRVC, is 56. And she's now on 80% PEEP of 12 and on a 4-to-1. And that's all that was changed was the IDE ratio, not the tidal volume setting. So my airway pressure is 56. So if I do that transition, so a P high of 56, right? Well, this ventilator would only go to 50. Okay, so that was at least some relief, right? So we set the airway pressure to 50, and I know this is going to be so, because that has to cause right heart strain, right? We had to absolutely cause right heart strain. Well, actually, we came off of the dopamine, off of the neosynephrine, off of the norepinephrine, and the dobutamine went from 20 down to 4. And that was with no change in anything but switching over to a different format of pressure, flow, and volume. So this unfortunate patient, this was 12 hours. You remember the original chest x-ray, 12 hours. And she was an organ donor. But the really important thing here is that she was able to transplant kidneys. So any other time they were ready to withdraw, they were going to actually, you know, with that blood gas and that chest x-ray, nobody was willing to, you know, roll up their sleeves and get in there. And she was able to donate both kidneys. But why does that not increase right heart strain? Well, as we know that at residual lung volume and TLC, you are at your highest pulmonary vascular resistance, but at FRC, you are at your lowest. So we took her from residual lung volume to FRC. Of course, if we put anybody in here on an airway pressure of even 20, right, you're going to be at TLC. But she was at residual lung volume. And Dr. Abashi likes to use the analogy of potassium. If I have a potassium that is normal, I'm not going to give 80 milliequivalents of potassium. But if my potassium is extremely low, I might need 80 milliequivalents to obtain a normal potassium. There's also a study done in Canada where they looked at right ventricular failure and that the effect of atelectasis. So they did a baseline echo, they de-recruited the lung, and they looked at how the left ventricle was underfilled, and then the right heart enlarged and blew up, and then post-recruitment everything went back to normal. But the interesting thing is that the lactate increased dramatically during this time of de-recruitment. So myth number 5, it's difficult to control PCO2 with APRV. And this is really interesting because there's, you can set a rate with APRV just like you can with any other mode. But for some reason, we've had this, set notion that the T high has to be 5 seconds, and that's absolutely not true especially when you're rescuing. And it's been APRV has been shown to be more efficient with CO2 removal with a lower minute ventilation. So here again is an example of a rate of 32 on conventional ventilation and the same rate of 32 on APRV, and we were actually able to, with a lower minute ventilation, actually this one had a higher minute ventilation because my volumes went up, but the CO2 was actually the same. APRV is the same as inverse ratio pressure control. This is very frequently stated that it's exactly the same. There's really no difference. It's extreme I to E ratios, and the inspiratory and the expiratory times are controlled directly and independently in APRV, unlike in inverse ratio pressure control. You have a rate knob and you have an inspiratory knob. You do not have an expiratory knob in pressure control. PEEP is not typically set with APRV, as you saw that, because time is the controller rather than pressure, and the crucial difference again is to set these independently. So if you look at the difference between here, I can set my inspiratory time and my rate, and I can set a T high at 1 second and a T low at 5 seconds, and they look identical. But the most important thing is I can adjust this to 75%, where I cannot adjust my PEEP or my release phase here to 75%. APRV creates unsafe auto-PEEP. Auto-PEEP. No evidence that auto-PEEP and dynamic hyperinflation occurs solely or with greater frequency in APRV than any other mode of ventilation, and the perception of auto-PEEP with APRV is conflated to assume that it only causes dynamic hyperinflation rather than a static end expiratory lung volume. Let's see. Myth number 8. That a P low if we set it to 0. And so there's a couple things here. A lot of people see that P low is 0 and say there's no way you cannot set that to 0. And we even heard this at a lecture. I don't care what you set the T low to, there will absolutely be collapse if you set that P low to 0. And the studies show also that there's less dynamic strain and alveolar patency when the P low is set to 0. So if we look here, we went through this and we showed that actually it retains end expiratory lung volume. And if you look here, this is an improperly set T low, and you can see a lot of alveolar collapse versus a properly set T low. And these are both with P low set to 0. Unable to measure driving pressure in APRV. This is also really interesting. So as Luigi went through various formulas for measuring driving pressure, if I measure my P plat, or in pressure control, my in APRV, my inspiratory pressure minus my PEEP, what's my driving pressure, right? But you can't use this. So what you need to do is an expiratory hold. And so we actually studied 200 patients, and we looked at all comers, any mode. So we looked at volume control, pressure control, regular APRV, meaning that they were always on APRV, or rescue APRV. And we looked at, we did a 6-second expiratory hold. All patients were either coming out of the OR, paralyzed. There was no spontaneous breathing. And I know, Luigi, I want to try that, where they are spontaneously breathing, but these are no spontaneous breathing. So we take 20, so 29 minus 20, and so that's going to be our driving pressure, right? So then when I do my expiratory hold there. So this is the, it was just an abstract. We're going to formally write a paper on this, that we looked at comparing the driving pressures, and what we found was that we collected in 200 trauma patients. We looked at volume control, 86 patients pressure control, APRV, we called it standard versus rescue, and that was because any other conventional mode failed. And the standard APRV group had the lowest driving pressure with a statistical difference compared to the volume control group and the pressure control group. But there was no statistical difference between standard and rescue APRV. And then the final, which kind of was it's interesting because both have been published, that you must be spontaneously breathing in APRV, but yet APRV spontaneous breathing is dangerous. So they actually wrapped around themselves, and again, there's no evidence that spontaneous breathing is harmful or associated in APRV, and we use APRV on all of the organ donors, which they are not spontaneously breathing, and there's no deleterious effects. So the bonus myth. So we reviewed these 3 studies in particular because they have been of great interest lately, I believe, on Twitter and some of the other blogs where they talk about these 3 trials. So the first one was the Hirschberg trial, and that a lot of people say it was stopped for harm because of the high tidal volumes. It was stopped for futility, not harm. And I'll show you, because the mode APRV was futile. It was not because the mode was futile. It was because the goal was not met. They wanted to keep it low tidal volume, but no matter what they did, they could not reduce the tidal volume in APRV. There's a possibility for that because they adjusted that T low to be either 50 to 75%. So you saw how 50% the volumes will go up, right? So if they targeted 75% solely, maybe the volumes would not have been as high. They had 3 groups, low tidal volume, 6 mLs, APRV, which they targeted 6 mLs, and APRV with no target. Even though the tidal volumes exceeded 12 mLs in both APRV groups, there was no increase There was no increase in barotrauma, mortality, hemodynamics, vasoactive requirements, sedation use, reintubation, free ventilator days, mortality, or ICU length of stay. No difference in either of the group. And that's with 12 plus mLs per kg. The second one is, this is a pediatric trial, and this one's really interesting. The APRV group, their primary cause of severe lung injury and ARDS, they had a much longer duration of respiratory complaints than the control group, indicating a sicker group of patients. They had an increased number of contaminated cases in the APRV group. We're still not really sure what that means, but they took them off APRV, they put them on something else, and then they put them back. So there was an increased amount of contamination in that group. The trend of barotrauma rates, sedation, analgesia, hemodynamic was actually lower in the APRV group. The T high, now this was set to 4 seconds in a pediatric population. That means that because of the ventilator they used and the lowest T load that they could obtain, we did the math, and the highest rate was 14 breaths per minute. So that's, going to have a lot of CO2 issues with a smaller, patient range. And they even state this in the paper that spontaneous breathing was a prerequisite, and they placed the patient on an alternative mode if they had poor breathing efforts. Again, this is this contaminated group that if they had CO2 issues, they took them off APRV, they put them on conventional to bulk ventilate them when all they had to do was reduce the T high. The T low, again, it could not be set lower than 0.2 seconds, and if you do not achieve that 75%, repeated alveolar collapse and expansion is never stopped. That if they could not attain a reliable P plat, the P high was set at 15 first, and then adjusted up to 28. So just imagine that time frame that it took for each sequential gas to get to 28, what the patient's effort was like. And if the tidal volumes exceeded 6 to 7 mLs per kg, the P high was reduced, and this could have potentially led to further de-recruitment. And this is just that what we were talking about. The adverse events also were higher in the control group and the APRV group. The pneumothorax was higher. None of these reached statistical significance, though. And then the final one, this was interesting because this actually came up at a recent pro-con debate in Minnesota, and this was inferred as fact that APRV group was stopped for mortality. Well, that's what they talk about in the paper. Here are the facts, though. After 4 episodes of barotrauma, a review by the Data Safety Monitoring Board recommended to stop recruitment, but they could not even reach a unanimous decision. It was still decided just to stop. Prior to stopping the study, though, there was no difference in mortality or barotrauma rates between the group, which was the impetus to stop the trial. Stracia in 2022 showed a systematic review and made analysis that increased barotrauma incidence was, again, associated with the severity of disease in COVID patients, not the mode. And they also talk, and we wrote this up, we also did an editorial and wrote this up about the APRV group suffered a hypercapnia, although the respiratory rate was lower than the tidal volume group. We even spoke to the authors, and they said their clinicians were not comfortable setting a T high lower than 4 seconds. So, of course, they had issues with hypercapnia. And this is perhaps the most interesting part. So, although the study was stopped for barotrauma, here's the difference in barotrauma rates. So, there was a total of 8, 4 in each group. So, it was because they said it happened in a different time frame. So, again, I'm only guessing, you know, I don't know, maybe the study was going on for 6 months and there was a pneumothorax here, a pneumothorax here, and this is in the tidal volume group, and then all of a sudden 4 in a week in APRV, which we know this happens, right? I mean, again, they're still 4 and 4, but yet the study was stopped. So we, this is the other thing, they actually, the T low settings, their expiratory flow termination, this is at the only point that it reached 75%. So in summary, we've been doing a lot of papers, a lot of studies, just looking at APRV, and we're looking at it in the lab, we're looking at it at patients, and we're just trying to actually answer questions, not trying to prove that this is, what everybody should be using at all times, but just to actually answer some of these questions and demystify some of these myths. So, any questions?